Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center. Twice per month I host a show about pediatric health topics where we take and answer your questions live. It's winter and that means colds, coughs, and bronchiolitis are spreading among children in homes, daycares, and schools. As a parent, do you ever feel helpless when your child's ill or wonder when you should bring them in to be seen by a medical provider? Today, we're discussing concerns about colds, coughs, bronchiolitis, pneumonia, and more. We want to hear your questions on this topic, so please send in your questions under the Facebook Live video feed, and we will try our best to review them during the live broadcast today. Joining us for this discussion are two experts and very experienced parents. The first is Dr. Mark Mannenbach, who is a board-certified pediatric and pediatric emergency medicine provider. He's provided care for acutely ill and injured children for his entire career in the emergency department setting. The second is Dr. DJ Hall, who is a pediatric hospitalist at Mayo Clinic Children's Center. He has spent his career caring for hospitalized and ill children. He's an assistant professor of pediatrics and is involved in teaching students at the Mayo Clinic Alex School of Medicine. Dr. Mannenbach and Dr. Hall, thank you so much for joining me today.
Thanks for having us.
So as parents and experienced medical providers, we've all cared for kids that have colds, coughs, bronchiolitis, among those other things. But sometimes there's some confusion about these topics, and I'm hoping that we can answer some questions for families and parents today. Dr. Hall, let's get you have you started. Can you explain to us what colds, or the medical term upper respiratory tract infections, are?
I think the first thing to jump in there and say is that a lot of people have a perception that they hear the term URI and they hear the term colds and they think that they're different.
Right.
And we as providers often use them interchangeably and don't necessarily go through what we mean. Exactly. So I think it's important to go out and define URI as being an upper respiratory infection. And when we talk about that, we really mean we're talking about the throat, the nose, and the lining that goes into your ears. And it's different than some of the things that we'll talk about later that we can be more worried about. And so what we see are viruses, and that's the primary cause of what's affecting this. There's some that are very common that have come into the common language, something like rhinovirus, which is the common cold. And what that leads to is just an inflammation of the lining of the nose, the inflammation of the lining of your throat. And that's why we see the symptoms that we do. You get exposed to a virus. Early on, you might have a fever. For children, that typically occurs in the first 1 to 3 days. At the same time, you may notice they start to be a little stuffy, and that stuffiness then leads to a runny nose, and then it slowly persists on. All of that, though, should be kind of confined to what we think of as the upper respiratory tract. So the nose, the throat, and occasionally they may complain of some ear pain, but often that doesn't occur until later on.
Okay. How long should parents expect these symptoms to last?
So I think the common confusion there is that colds in adults actually last a shorter amount of time than they do in children. So if one of us have a cold, then we expect our symptoms to go away really from anywhere from 3 days to 7 days at the most. In children, though, cold symptoms will last a minimum typically of 5 days, but on average, it'll be closer to 10 days. And then if you have a cough or illnesses like that, the cough can persist even into a couple of weeks of time. So, but I'd say 10 days is a pretty good rule of thumb to follow.
Okay. One common thing that I hear in the office is, especially babies in that first year of life, parents are saying, my kid is constantly having a runny nose, they're constantly sick. How common is it for kids to have multiple URIs in that first year of life?
So the first year of life is the time that the body's exposed to the viruses the most, and it's your first encounter with them. And so you're going to mount a response to each of those. And often the symptoms we're seeing really is your body responding to viruses.
Exactly.
And so it's not just the virus causing a problem, but your body having a runny nose is actually helping it shed the virus and shed the viral burden. So while it can be an annoyance and you may think that it's going on forever, you actually are right. Most children will have between 6 to 8 colds a year. And again, if we're thinking on the idea that they can last 10 to 14 days, that's a lot of time that your child's going to be sick. Kids in daycares, it's going to be even more. And on average, then we're talking 10 to 12 colds a year. So now we're thinking almost half the year your child's going to have viral symptoms. So having been a parent and having a child at home right now who has a cold, I can sympathize with them. But it does get better over time, and colds do decrease in numbers. So by the time a child's school age, we're thinking more on the lines of 4 to 5 colds at most during the course of a year.
Okay, so what can you do to help support your children when they have these symptoms?
There are lots and lots of things out there that will advertise themselves as cold remedies. Unfortunately for children under the age of 6, none of those are recommended because they're multi-ingredient medications. And so while you may think that you're giving them simply acetaminophen or Tylenol to help relieve pain or aches or even fever, there are other medications in there. So we really want to avoid any of the over-the-counter cough and cold medicines. But what you can do, make sure they're getting plenty of liquids. We can do symptomatic treatments with things as simple as honey. Honey's been shown to be highly effective in reducing cough. And then other things that we can do is making sure our child has a well-rounded diet other times of the year. We hear a lot about giving vitamin C during the course of an illness, but really it's getting vitamin C and things like that in advance as opposed to taking it at the beginning of a cold. That's really going to change your symptoms.
Absolutely. We have a great audience question about this, and they're asking more about the holistic or complementary medicine. They're asking about peppermint, garlic, and ginger. Do you know of any evidence to support that this is helpful in treating the symptoms?
So there's no studies that I'm aware of, particularly around garlic and ginger. Again, the idea of starting a supplement at the beginning of a cold, the likelihood that it's really going to be effective at that point in time is pretty low. Right. You're going to see your symptoms of colds not until 3 to 4 days into the illness. Right. And so by then, starting a supplementation is probably not going to be that helpful. If you do have a child that's nauseous, though, there are some good suggestions that peppermint can be helpful for children with nausea. And so it's certainly something that's open to trying. However, being careful with things like peppermint, knowing that in children under the age of 5, things like lozenges or hard candy really aren't recommended.
Right, choking hazards and whatnot. And the other thing I would add is all the over-the-counter supplements, complementary medicine, ingredients, those are not regulated by the FDA. So we don't necessarily really know what's in there. There's been concerns in the past with some of the teething tablets causing symptoms as the ingredients are not regulated. So
Sure.
Yeah, something else to think about. Okay, so Dr. Mannenbach, so in the emergency department setting is where you are seeing these children.
Right.
Okay. When should parents be bringing their children in for medical evaluation?
That's a tough call, you know, and I empathize. I remember when my first daughter vomited for the first time in her life, I was
Right.
scared, terrified.
Right.
I'm like, why is this happening? So I understand it. It's challenging. I think part of it is duration of symptoms, probably first of all. As DJ said, many times the typical time frame is 5-7 days, but if it's getting beyond that period of time, especially with persistence of fever over that period of time, that's a time for me to think, well, what else could be going on? Especially for those kiddos under a year of age, under 2 years of age. It's challenging. I mean, the children can't tell us exactly what's wrong or what hurts or what bothers them. So we certainly empathize with, you know, when is the right time to come in. I think largely parents know their children best. I often ask the question in the emergency department, well, what have you seen that's different? What's striking you as being concerned enough to bring them in? Because that's usually what we want to address. We see them for a short period of time in the acute care setting, in the emergency department where I work, but I really need to hear their perspective over what they've seen that may have changed. In particular, I think if they have rapid breathing, even when their temperature is down, even when their nose has been suctioned out, if you consistently see rapid breathing, labored breathing, grunting kind of sounds, really just poor feeding and poor liquid intake, those are the kiddos that I'm really worried about in the setting of cold, cough, runny nose kind of symptoms.
Absolutely. How do we know when a cold is just more than a cold? When does it start to become something else?
Yeah, I think, again, duration fits into that.
Okay.
Their work of breathing is certainly a big issue. And that's why, you know, asking again parents' perspective, have you tried suctioning the nose? Yes, I have. Well, has that made a difference? Well, no, it really hasn't. To me, that's, again, another red flag of the things that we typically try, the things that DJ talked about of helping the colds, just doesn't seem to be making much difference, and they're worried. Their activity level is also something I always ask about. Are they the kiddos that, you know, are just laying around on the couch now? Are they generally very, very active, and now they've lost their energy level? Those are the kiddos that I really start to worry about with the parents.
Okay, so we have something that Dr. Hall described as mostly being viral, right? But how is it that towards the end of the illness that sometimes we start to worry about things becoming a bacterial infection?
Sure. Well, we can all have bacteria in the back of our nose and throat that, in a carrier kind of state, if you will. We certainly can be exposed to others. But I think when those viruses that DJ talked about really start to get into that nose, throat kind of area, they change the lining and protective aspects of our respiratory tract. And those are areas in which bacteria can then kind of take hold or really kind of change the illness, gain an advantage over someone who really isn't able to shed, or I should say, protect against those viruses.
Okay. So what are some of the bacterial infections that can occur at the end of a cold?
Well, I guess the more common one would be ear infections, which again, we're not always sure are viral or if they are bacterial, but we presume that they are in younger children, especially those under age 2. So if your child's had a lot of problems with ear infections, you probably are a pretty good judge of when that's kicking in again. Are they pulling on those ears? Are they refusing to suck on their bottle or their pacifier, refusing the sippy cup that they normally would? Those are probably signs that that might be ear infection going on. We don't treat all ear infections with antibiotics, but again, if the kiddo's had a lot of problems with those, or if they're really uncomfortable and not getting better with the acetaminophen, the ibuprofen medications, well, that might be a time to say, let's get a good look at those ears, and maybe they do benefit from some antibiotics. Okay. So that would be the most common.
What about pneumonia? Is that something that you typically see, or is it less common?
It is. Certainly the viral part is much more common. The challenge for me is, which kiddo in this respiratory season is the child that truly has a pneumonia.
Right.
That's challenging for us as well. We see a lot of kids with these similar symptoms, and there's certainly overlap with the kid with the respiratory cold and the respiratory pneumonia. So again, fever for a number of days. The typical things we look for are fever, cough, and rapid breathing. We have the advantage when you come to the emergency department, we're also measuring oxygen levels. We're observing how the child's work of breathing as well. So if the child seems like they're really tugging in with rib muscles, tugging in with chest muscles, grunting again, as I mentioned earlier, those are the kiddos that I worry about that have a true pneumonia that might need treatment.
Absolutely. So we often hear people saying yellow or green snot. Is it happening maybe towards the middle or the end of their cold? Is that something we worry about as medical providers?
Well, I don't want to dismiss it completely. Sinus infections are pretty uncommon in younger children. Their sinuses, to a large extent, haven't even developed yet as they are in adults. Persistent drainage beyond the typical time of a cold, yellow, discolored, greenish, certainly we start to think about that. But even if it's green and yellow, it's most likely still a viral cause, especially early in the course of the illness.
I think the big thing there for us is that when you're thinking about coughs and colds, the cough is really what lingers for most patients. So the idea that if the congestion has gotten better and now we're 7 to 10 days in and the congestion seems to worsen or not be getting, then again, it has less to do with the color and more of the persistence of the symptoms.
Exactly.
Or if you are pretty far into it and a fever were to occur. So whether that be thinking about ear infections, sinusitis, or pneumonia, we really think about that fever occurring early on in a viral illness and slowly going away. So having a fever develop after a week of being ill would be a sign to go in and be seen. And at that point, your doctor is really going to take the time to look in your ears. They may ask you some questions that point more towards a sinus infection. And they'll certainly, at minimum, listen to your child's lungs to think about pneumonia.
And this, sorry, Dr. Mattke.
Well, yeah. I think, again, we have to be careful in the midst of all these. We certainly don't want to miss the things I talked about, the pneumonia, which child has that going on. At the same time, we have to be careful about using antibiotics too much.
Exactly.
The resistances that are out there over the course of my almost 30-year career now are impressive. Antibiotics that I used early in my career and training just simply aren't effective anymore. We don't even try because we know they're unsuccessful. So we have to be very good stewards of antibiotics and say which child truly needs these antibiotics, which one doesn't. Because again, the side effects of the antibiotics sometimes are worse than the illness itself as well.
Absolutely. So just want to help clarify for families, if the child is backing up, so most kids if there's concerns for fever or they're not drinking well, or maybe starting to work a little bit harder, they can be seen usually in their primary care office. But when it's the kids that are looking more ill, they can probably just skip their primary care and head straight to the ER.
I think that's true. Yeah, if they sense that this is beyond what they've already maybe talked about with their primary care provider, and they see things getting worse, especially in the off hours. I mean, that's what we're there for. That's what we're there to try to help sort through with the families as well.
Okay, sounds good.
A lot of the advice we're giving right now, I think you can even get from your nurse line through your pediatrician. So using them as a first resource, they're going to help you triage. They're going to go through some questions that may help you decide, can this wait until tomorrow morning, or should you be seen more urgently? Specifically, they're going to help walk you through some of the symptoms of difficulty breathing, and help you pay attention to those things. So feeling comfortable and knowing how to use those resources can be really helpful.
Absolutely. You mentioned coughs, Dr. Hall, and that was a perfect segue into kind of moving on into our next kind of infections. So we talked about upper respiratory tract infections, and now we're going to kind of move down to talk about infections that are in the lower respiratory tract. One that we are seeing right now that we talked a little bit about before the show is called bronchiolitis. Can you tell us a little bit more about that?
So bronchiolitis is perhaps one of the more common things that a child will experience. We know that a lot of children will have bronchiolitis by the age of 3. It's almost 100% at that point in time. And going back to what Dr. Mattke just referenced, early on we talked about upper respiratory infections. So those infections that affect mainly the nose, the throat. Bronchiolitis is when we finally move down into the lower airways. And it presents with a lot of new symptoms. The first thing that people will notice is more of a cough. And so the cough can still be secondary to just congestion, but there's also probably some irritation further into the airways. Bronchiolitis is caused, again, most commonly by viruses. The one that people hear a lot about is something called RSV. RSV is the most common reason for bronchiolitis, but it's not the only reason for it. And so even if your child is swabbed at your pediatrician or at an urgent care and found to be RSV negative, it doesn't necessarily mean that they don't have bronchiolitis. So that's something that we'll definitively we're in the middle of right now. The symptoms will, the seasonality of it here in the Midwest, January and February is when we'll see bronchiolitis the most, and it will slowly start to go away as we get into the spring.
Okay. What are the typical symptoms? Is there a predictable pattern that will present with the children?
So I think part of why we kind of go through the symptoms of a cold and upper respiratory infections the way we do is if you can solidify that in your mind as a parent, you can start to understand a little bit more about what bronchiolitis might look like. So the child that has bronchiolitis often looks like they have a cold for the first 1 to 3 days. They may have a fever. They may be a little less energetic. They'll definitively start to have congestion or a runny nose. But what you'll experience is that typically sometime between day 3 and 5, the cough becomes the more predominant symptom. You may even notice that your child is wheezing and they might have difficulty breathing. So it's the symptoms, again, will start with cold-like symptoms and they'll proceed into what seems more like it's involving the lower respiratory tract, and that is those symptoms of wheezing, the more persistent cough, and more signs of difficulty breathing.
Okay. What age children are most likely to manifest these symptoms?
This is really the first big illness that most children will have in their life. So we're thinking in the kind of 3 to 6 month time frame is when you're going to see bronchiolitis the most. But definitively, it's an illness that likes to be in children under the age of 1. You can develop bronchiolitis more than once, and certainly can develop bronchiolitis even into your toddler years, but it becomes less common. Some of that is just the physiology that we talk about with bronchiolitis, or how it attacks. So the smaller your airways, then the more difficult time you're going to have with airway inflammation or mucus building up in your airways, because you can't fight it off to the same extent.
Right, exactly. When should parents bring their child in with these symptoms?
So I think that's an important thing, because not all children that get bronchiolitis need to come into the hospital. And certainly they don't really even need to come into an urgent care or an emergency department setting. When they do need to be seen, will be signs that your child is breathing so rapidly that it's interfering with their ability to eat or drink. You're noticing that the pattern or the way they breathe has changed. So you'll see the skin being pulled in around their ribs or above their sternum. So we call those retractions. So they're pulling harder to breathe, or you notice that their belly or their abdomen is more involved in breathing than it normally would be. Often, though, at this time of year, your child's going to be pretty well covered, so you may not notice that. So if you notice that your child's nose seems to be flaring out more than it would have before, Or if your child certainly in less than 3 to 4 months develops a fever, they should be seen and evaluated.
Absolutely. So, Dr. Mannenbach, you've seen a lot of bronchiolitis over the years, and the treatments for bronchiolitis have changed slightly over the years as well. We have a great audience question about the treatments, so can you take it from here?
Well, it's a frustrating illness. It's a frustrating illness for families because, again, very young children, not feeding well, not sleeping well, no one's sleeping well in the home. It's a big challenge, right. and it's really hard for the families. It's hard for us as providers because we wish we had the thing that was going to make them better.
Right.
We're not keeping it from them. We're not holding it back. But we've tried a lot of different things over the years. And if you really look at studies and our own experience over time, we find that a lot of those things we've tried have not really made any difference. As I mentioned earlier about antibiotics won't help bronchiolitis. It is a viral problem. And we'll again just add side effects. Diarrhea, skin rashes, vomiting can go along when we start adding antibiotics. And really, support is what children need for bronchiolitis. We've tried nebulizer treatments and not found them to be very successful. Right. We might try them, observe. If it makes a difference for a certain child, especially in that toddler that DJ talked about, right. Then that's something that we might continue because we've seen some improvement in real time as we evaluate them and reevaluate them. But other things that have been tried include steroids. This is different than asthma. This is not constriction of the breathing tubes as much as it is the mucus and phlegm lining those breathing tubes and making them stick together. And then the children have to try to overcome that increased resistance in their breathing. And the way they do that is they breathe faster. They use those tummy muscles. They use those rib muscles to try to overcome that and to be more comfortable.
Okay. Yeah. Is there anything that parents can do to help support their child?
Well, again, a lot of these children are infants, and infants are nose breathers. And so when they are plugged up in that nose, they struggle, and they will struggle especially when they're trying to feed a bottle or at the breast. So suctioning their nose might not get all of that mucus and phlegm from those small breathing tubes, but it might open up the upper airway enough so that they can feed better, they're better hydrated, they're more comfortable, more content in that way. But beyond that, again, the cold and cough medicines are not going to make a difference, and again, probably cause more side effect, certainly, than any help.
Okay. So for both of you, you're seeing these children in the ER and admitting them to the hospital. How are you guys deciding if these children would need to go into the hospital? What kind of criteria are you using?
Well, we try to be as objective as we can. There are children who are breathing somewhat fast, but they're alert, they're smiling, they're feeding well. We check their oxygen level, it's very good. Their color is very good. Their hydration is very good. I call them happy wheezers, and I'm encouraged by that.
Right.
I understand it's frustrating, but bringing them in the hospital, there's probably not much more we're going to add to that. And at the same time, I worry about what else we're going to expose them to if we do hospitalize them. So the criteria are if they need extra oxygen, if they are working so hard to breathe that it interferes with their ability to take even fluids and they're dehydrated. Those are the kiddos that we really start to worry about. The younger children certainly benefit, I think, possibly for closer observation. And the children who, just really are already showing signs of illness, but very early in the course. They haven't yet peaked. As DJ said, you're going to peak with this illness about day 3, day 5. We hope, and then slowly improve, and I'm sure we'll talk more about that, how long it takes to recover. But if they're on day 1 or day 2 and they're already breathing fast and their oral intake is down, that might be a child we kind of know, and they're 3 months of age. That's a child we might be more inclined to admit and observe because we're not sure which direction they're headed just yet.
Is it common for these children to be seen multiple times throughout the course of this illness?
It is.
Yeah.
And I don't see that as a problem. It's challenging for families. It's challenging for physicians. I can listen to a child's breathing and not hear any wheezing at all. Maybe see some rapid breathing, come back in later, and they're actually wheezing more. This is a constantly changing illness, both minute to minute and then over days. So I encourage families, if this is what we have right now, I think it's okay to go home. But if you see that things are getting worse, we should see them again, especially again if it's early in that course of illness.
I think we're fortunate now too with the ability for families to capture some of the symptoms at home, whether that be through a video on their phone, or through other social media resources, of finding a resource online that can better describe what they've seen in their child. Because it can be really frustrating to come into the emergency department or into your pediatrician's office and the symptoms to not be there. A lot of the things that kids do at baseline, so crying, taking bigger deep breaths because of that, the cough can actually change the exam that we as physicians are hearing. And so that's why we can hear wheezing at one point, or we can hear extra sounds of their lungs that go away, because the child's actually opening up their lungs. And so it's a reassurance to families like, yes, you did the right thing. Those were the right things to watch for. And also, if you have questions about, is this retractions or not, those are great things that you can discuss with your pediatrician, and they can kind of help you walk through the whole process and maybe not have to go to the emergency department.
Absolutely. Why don't we worry about a bacterial pneumonia in children who have bronchiolitis?
Well, again, that's the benefit of someone doing a really good exam on babies, taking the time to listen well to their lungs, to recheck that oxygen level, to count their respiratory rate. And each time these children might come back to the emergency department, that's what I have in mind. Has anything changed here that I'm worried that something has gone on from there? But generally with bronchiolitis, what I'm going to hear is diffuse wheezing, meaning both sides, up and down, front and back. And I might see some, as I mentioned earlier, some overlap of symptoms with pneumonia, but that kind of wheezing all over kind of thing is not seen with bacterial pneumonia. Again, if we really can't tell from the exam, if we really don't hear that as much, or it's changed from the previous visit, then we might say, well, this is the time to think, well, we should do a chest x-ray, because we don't want to overdo that. We don't want to expose children to multiple x-rays over time. And so doing a good thorough exam, getting input from families as to what they're seeing and hearing over time, really kind of helps us decide, well, is this just bronchiolitis, or is it something more, something that would benefit from chest x-rays or antibiotics?
Dr. Hall, I have a very good but difficult question from one of our audience, and they're wondering, why are some medical providers still prescribing some of these treatments that we discussed that aren't helpful, if they don't work or if they don't help these children?
So I think that's a common frustration, both for us as providers as well as for families. Families are hopeful that we'll be able to find something that can help. We do know that there's a small percentage of children that things like albuterol, or what we call bronchodilators, might help. And so if there's a chance that it will help, providers will try that. If you're in a primary care setting, it's hard to be able to provide that and then see whether or not they had the response. They don't have the ability of time that Dr. Mannenbach and I have in our clinical settings, where we can give a medication, observe for a certain amount of time, and then see the impact. And so it can be easier to do those as an outpatient, just to prescribe it and ask the family to see if it works. Some of the other things, though, it's just the dissemination of evidence. So depending on when you trained, you can have been in line with a new treatment that was coming out that was thought to be effective, and has, with later and subsequent studies, shown to not be effective. Providers, though, I think also feel comfortable with some of these, because things like albuterol or saline sprays have very low side effect profiles, so you can feel a little bit safer about providing them if you think you're just getting symptom relief. But I think it's always good to ask your physician, what should I expect from this medicine that you're providing me, so it kind of helps you understand why you're getting it and whether or not your child's getting the intended benefit.
And at times I'll ask, again, the family's perspective, well, you've tried these nebulizer treatments or these inhaled treatments. Have you seen any difference? Has it been of some help? If it has been, that might be something that we continue. If it hasn't been, well, I wouldn't be surprised, because bronchiolitis generally, we know, does not respond well to these inhaled medicines. It also raises the question again, and reminds me to look and listen and say, well, could this be, again, a pneumonia or something different than that? I think providers are just trying to help. I think they really would like to see these children get better, if at all possible. It's hard to not have a whole lot to offer them.
And I think it's like, as you mentioned very well, it's frustrating for us as providers too, because we wish we had a magic bullet that could make them get better, but unfortunately, time is often the treatment that's going to be most helpful. So we have another great audience question, and we were discussing this earlier because we're starting to see influenza in our clinics and in our hospital and the emergency department. Dr. Mannenbach, how do we tell the difference between cold and flu, or bronchiolitis and influenza even?
Well, again, they're all viruses,
Yeah.
right? So influenza can cause bronchiolitis. As DJ mentioned, respiratory syncytial virus, or RSV, can cause that as well. So any virus can be the trigger or cause for bronchiolitis. Whether we name it or not doesn't really change our treatment for the most part. I'm interested in testing and or treating or finding influenza for children who are at high risk. So if they have underlying medical problems, seizure disorder, diabetes, if they're being treated with chemotherapeutic agents, they're extremely vulnerable to getting very, very sick. And so we may test to find out if that's indeed the case. If it's positive, then maybe we avoid some other testing. At the same time, there is the thought of prescribing antiviral medications in the hopes of shortening the illness by a day or two. But the overlap of these things is quite a bit. So what might start out as a simple cold could easily be the beginnings of influenza. Again, you hear a lot about influenza and influenza-related deaths in children. That, again, is usually a complication. A pneumonia has developed. And again, high-risk groups of children with underlying medical conditions are those that, again, hard for parents to determine how sick are they based on their symptoms. And so, again, working with them, I think we can try to see which child might benefit from testing and or treatments.
Great answer. Dr. Hall, this will be our last question because we're coming short on time, but dehydration is one of the things with bronchiolitis that we're worrying a lot about. How can parents either prevent or treat the dehydration at home?
So I think going all the way back to the very first suggestion, which is suctioning of the nose. So in infants, the ability to help suction their nose is going to help them to be able to eat because the majority of what they're doing is still using bottles or using sippy cups, all of which require them to amount some degree of suction themselves. And if you don't have a clear nose, then you're not going to be successful. The other thing is just knowing that you can offer small amounts more frequently and not anticipate that they'll be able to drink as much all at once. Also know that your child can have cough, and that cough can cause them to vomit afterwards. I think all of us as parents have experienced this phenomenon. And while it's not something that you're excited to see, you also know that it's to be expected. And so knowing that that's expected can help remind you, giving them just smaller volumes than they would typically take. And even that could be half of what they would typically have. And just offering it throughout the day. A lot of the things that we recommend as general pediatricians about not letting a child just have sippy cups all over the house kind of goes away when they're ill with colds. And so making sure they have lots of opportunities, lots of availability of different liquids that they like to drink. But do know that if they come in the hospital, that's one of the things that we're most concerned about. And so we will think about other ways of making sure they get fluids and providing them in a way, because fluids and calories are really going to help a child fight through this. And it's the inability to drink is really what gets the most kids in trouble.
Absolutely. Well, this was fantastic. Thank you so much for both of you offering your expertise to our families today. Do you guys have anything else to add?
No, I don't think so. I wish there were simple answers for these challenges for families. Parents, again, know their children best. We're here to partner with them and do our best to see what has changed or not. So, as you mentioned earlier, the repeat visits are not failure on anyone's part in my mind. We really need to make sure that we're not missing other things that are going on with these children.
Yeah, and I think the most important thing that we would add probably is prevention is key. And so know your child can get colds, but good hand washing, paying attention to who your child might be around. You can't avoid daycare, but you can avoid things like smoke exposure. And so secondhand smoke exposure increases your likelihood of having viral illnesses significantly, and also increases your likelihood of having to see one of us in the clinical settings where we work. And to remember to get vaccinated from influenza, both not only for the child but for the family, because then you don't have to think about that variable as much on making the decision about really what's going on.
It's a great way to end. I always love to end talking about vaccines. So, all right, thank you for joining us today. And that's all the time we have, everyone. You can join us for the next Ask the Mayo Mom on February 7th. It'll be at 11 a.m. Central Standard Time. We'll be talking about gross and fine motor development in children and when you should be concerned that a delay might be present. Thanks, everyone who watched and sent in questions, and everyone stay warm out there. Have a wonderful day.